Hello, this is Fernando Gomez Sancha again. It's been a while since I didn't post a video, and that is because I felt that all my knowledge is already on the videos that I already published. But of course, in this case, I want to show you the new Magneto laser in action. You know that Magneto is a new laser console that allows to use the pulse modulation settings that we already had with this cyber Holmium laser. So we use virtual basket for dissection, but then you can have this Magneto setting that emits longer pulses similar to Thulium and Thulium fiber pulses. So now in the same machine we have the ability to use the former Holmium settings, but also we have this Magneto effect or Magneto setting that has nothing to do with magnetism. It's just a commercial name, but it allows to emit longer pulses of Holmium, which is quite new and quite unusual because, as we know, the pulses emitted from a Holmium laser up to now were quite short, and that produced the excellent opening of the plane that we love for Holmium enucleation. With this virtual basket setting, the pulse modulated double bubble, we could get enhanced dissection and coagulation at the same time. And this is a setting I'm using at 2 joules and 50 hertz, as I usually do for dissection. But I'm going to use the Magneto setting for hemostasis. So in this machine, you can emit pulses that have a length of, I think, up to 2000 microseconds, which is much more than the previous longest pulse duration, which was 1100 microseconds. So the pulses of Magneto are much longer. You can use the Magneto settings with combinations of energy and frequency that will be less than 32 watts. So it's going to be an enhancement in the ability of this laser to treat stones, but it's going to be a great enhancement, and I think my personal impression is that this is going to be very, very relevant, and it's going to be an addition that will make us surgeons much more comfortable with what we are doing, because we will have a much improved coagulation. Okay, this is a bleeder coming from the adenoma. These are notoriously difficult to coagulate, so I almost never pay attention to them. So I gave it a try here, even with Magneto, and it didn't stop. But you'll see, because this case is special in the sense that it was a very demanding case. This man had a catheter. He was on refractory urinary retention, and his prostate was over 200 grams of volume, as determined by MRI and ultrasound. So it was quite a big prostate. He had a very high blood pressure during the operation, so it was at 170 systolic pressure, which couldn't be lowered by the anesthetist. They tried several strategies, and he kept this very high blood pressure, and it was a very, very bloody, very, very bleeding prostate, in the sense that despite using virtual basket for dissection, you will see that when we return to the dissected area, there is a tendency to bleed. So I was really, really happy that I could have the Magneto setting to coagulate at, I think it was 1 joule and 30 hertz setting, of course with the Magneto setting turned on for coagulation. Okay, so here you can see this is the usual technique that you have seen many times in my other videos, where I tried to do an early apical release, trying to protect the sphincter mucosa. So I started by marking the white line, as I usually do, and then I started developing the entry into the posterior plane in one side of the verru, then the other side, then I communicated both planes in the midline, and this is the development of the posterior plane. So here you can see this is virtual basket in action, trying to develop the posterior plane. You can see there's blood in the medium, which is not so common, not so usual, and this is because of these special characteristics of this patient. Very, very hard, very large prostate, and this, probably this very, very high blood pressure during the operation. And of course, big prostates come with bigger vessels also. So sometimes we all have the experience that we find larger vessels and more complicated hemostasis to be carried out, especially prior to morcellation, because you have a big fossa. You have to have very good hemostasis, because it's going to be a little bit longer morcellation. So it's a double challenge: the size, the tendency to bleed, and the need to get very, very good coagulation. In this case, the total operative time was 1 hour and 15 minutes. So you see that despite the big size of the prostate, if you are able to work slowly, carefully, but consistently, and keep the laser activated and keep dissecting, keep dissecting. Even if you go slow, if you're constant, if you don't stop too much, then you will be able to progress. So you see, this is the coagulation setting from Magneto now. So I experienced it. Normally, when I operate with virtual basket, there's very little need for me to use the coagulation pedal. That's because virtual basket generally gives us a very, very good coagulation, first pass coagulation, so we get very nice hemostasis as we go. But of course, occasionally you have to insist in hemostasis. This is now the ascension in the lateral plane, trying to cut the apical attachments first, and then progress towards the bladder neck a little bit, because if we don't mobilize the apex, we don't get access, we don't get space enough to reach the anterior part without tensioning the sphincter. So here, as you see, I come back to the apex, gain some access by cutting the apical attachments, and then I try to progress towards the bladder neck to gain mobility. Okay, so normally, as I said, virtual basket gives you very good cutting and dissection properties and coagulation as well. But of course, when we encounter bigger vessels, or when we encounter that we are taking a relatively deep plane, or in this very large prostates, often the plane is very thin. The capsule is very thin because it has been distended too much. So we get very, very big adenoma and a very thin capsule. Often you can go a little deeper and then find that the surface has a much bigger tendency to bleed. Okay, so here we are. This is the apex. You can see there's some nodules at the apex. So even when we are at the level of the white line, we want to remove these nodules. We don't want to leave BPH nodules remaining hanging from the apical area. So here what I'm doing is one more time coming to the apex, trying to cut the apical attachments, and then try to continue the ascending dissection. Often these nodules, get on the way. They don't let you see it. It's a little bit cumbersome, but it's not a big deal. Trying to go up and trying to make sure that we take the most peripheral route, so we don't cut through the adenoma at the anterior apex and leave anterior tissue there. So again, as you can see, I'm trying to mobilize, and at the same time, I'm trying to have a line of dissection that I can easily recognize. So you see, I work a lot on making sure that the line that we bring from below, from the posterior aspect, continues. It's communicated, it's continued by going down again, you see, and trying to check that the line is a uniform line. It's super important to carry uniform lines. I think this is all virtual basket, no need to change to Magneto normally, and this is because of the economy of the procedure. You don't want to, stop and start when you can keep lasing, and if it's efficient, if it's if it coagulates the tissue enough, it's probably better than stopping and starting. So we will use Magneto, for example. This is probably now Magneto because I thought that was a little vessel. And also when you see that there's bleeding in the area, sometimes you have to stop a little and look for the bleeders. Here, this is the 12 o'clock region. When I did the white line at the beginning, I didn't connect at 12 o'clock because at the time I had to force too much to get there. And my feeling is that the sphincter in the first moments of the operation is a little bit more tense. It has more tone than when you have already been operating there for a while. So often, if I cannot reach the 12 o'clock without forcing, and for the same reason, you could see that I didn't enter the bladder at the beginning, because often if you want to force the entry to the bladder, you will see that the sphincter splits at 12 o'clock. So you're going to damage the sphincter. And that's why I try not to force the sphincter. But of course, after some time operating, you feel that the sphincter has given a little bit. The tone is less, it's more relaxed, and you can reach without needing to do much force. So again, here we are trying to make sure that we have a nice line that connects, that the lateral line of dissection is clearly visible. Here I was seeing that there's adenomatous tissue anteriorly that is a little bit difficult to reach. This prostate was very tall, and how do you say that? With the patient lying down, the posterior anterior diameter was quite long. So, but there I am, trying to improve things, trying to move slowly. I am, let's say, more careful when I do very large prostates with hemostasis. Of course, with a smaller prostate, you can be a little bit more dynamic in the dissection, because if there is a remaining bleed or something, you can always, go back and coagulate. But in many cases, we can move forward a little bit faster. But in the large prostates, I tend to be very, very careful and try to move slowly, because I want to make sure that I don't have many vessels bleeding at the same time. So you see, and this was a very highly vascularized prostate. And you've been there. I mean, if you do HoLEP, you can see that sometimes the prostates are quite challenging. As I usually say, the prostate is a formidable enemy, and despite having a good laser, despite having a lot of experience, sometimes we are still challenged by the difficulty of these cases. Okay, so that was at 12 o'clock. I think it was enough to start the ascending dissection on the other side, and you can see that there is some clot formation where we haven't been working and irrigating, so there is a tendency to bleed, and that is making things slightly more difficult. Okay, so this is the up and down movement I do to enter the lateral plane. I don't go up very much because I don't want to stress the sphincter, and of course I come out to try to deepen the white line a little bit. This is white line, So I'm going to cut these attachments between the sphincter and the apex of the prostate to try to make sure that I preserve the sphincter as perfectly as I can. And you see, I like to do the white line at the beginning because I think often in cases like this that are slightly more difficult, you have difficulty to distinguishing where is the apical limit of the operation. And if you have a white line, you can recognize much easier where are the limits of the operation and not make mistakes there. Okay, so this is now lateral plane development. You see that I like to do wide movements, so the fiber goes up and down, but not in a short distance, but I try to, move and do long movements that will make sure that the line that I'm drawing with my laser on the prostate is more or less uniform and continuous, and is going to help me guide my dissection, is going to help me recognize the limit between the prostate and the adenoma. And I am understanding that this is an integral part of being able to operate all the time. So many surgeons need to stop and go back, like I'm doing now, to see, to understand. But most of the times I have learned that if I carry this very, very nicely drawn lines on the capsule and the limit with the adenoma, I can keep on working, and I don't need to go back to look, and I don't need to stop so often, which is helping in the speed of the operation. No? I'm not trying to run, but of course I want to be efficient with time, and I will see. Here, for example, I was also not sure if I was going up all that I needed, as much as I needed. Sometimes you fear that you are cutting through the adenoma apically, and so I decided to do a little bit more liberation, which is always good, because then you have better access and better understanding of the planes. So here again, coming up and down, you see that I tailor the speed of movement depending on the response of the tissue, and in some moments you can progress a little bit faster. Sometimes you need to be very slow if you want to have a better hemostasis. No, but you will see that the man had a very high blood pressure, and it is a much more bloody operation than usual, and I have to say that I felt very, very safe having the ability to use Magneto to go through the bleeding areas and get proper hemostasis. You will see that several times I will need to resort to Magneto. Here, when we come back again, you see that there is also a little bit of clot formation. That's the 12 o'clock incision. But there was some apical tissue, and it was not so easy to know if I was on the right anterior plane. In these cases, when, for example, you are quite happy with the height of the plane that you have achieved, and you're quite happy that there's no adenomatous remnants in one side, you can try to, let's say, take the dissection from the good side towards the less clear side, like I'm doing now. So I'm coming back to the good side and try to see. You see, that looks like nodular, so we need to go even further up. So we want to remove all this apical anterior tissue. So it doesn't. I never hesitate to re-explore or to deepen a little bit the dissection line if I feel that I am leaving tissue behind. If when you deepen your incision, you find that you're getting too deep, of course, you can always go back to the previous depth. But here you see I was a little bit struggling to get all as much anterior as I needed to be. So you need to keep the faith, and you need to do these long movements trying to connect the lines. And lately I'm telling everybody who comes to watch operations with me that with HoLEP, often the information you need is not on the screen. It's not all of it, because some people think if I am guiding my movements because I am of what I am seeing in the screen, and it's not completely true. You have to look at the screen, but you have to keep in your mind the 3D anatomy of the prostate. You have to remember what you saw, some minutes ago. You have to remember the degree of development of the plane that you had, on the other side. And so, of course, the information in the screen is very, very important, but often you have to, let's say, also imagine a little bit to try to understand, what's going on. And also, of course, we have a knowledge of prostate anatomy that we get from watching, MRI studies, from previous surgeries. So you have to combine all of this, the information on the screen that mostly confirms what you are suspecting, what you think you're doing, let's say, and try to advance. Here you see a little discrepancy in the plane. So with the plane we took from the left side of the patient towards the right was a little bit deeper than the plane that we were carrying from right to left of the patient. And here, as always, I'm trying to make sure that the lines connect, that the line that I was carrying on the lateral plane, is connecting to the posterior. So I think the apex is already released. We call it early apex release, which of course is not an immediate apical release, because we want to, let's say, prepare things so that we can do the early apical release with the lessening the stress to the sphincter as much as possible. So probably I was using Magneto in some of these coagulation moves, but I think we're going to have a lot more of that later. And here we are now progressing to develop the anterior line. This is still lateral line. You see, I'm trying to do a uniform line. I'm trying to draw with my fiber like an artist, that is doing a drawing. And of course, trying to keep a good hemostasis during the procedure. It's interesting to watch the videos after surgery, because you might remember the operation in a certain way, and then when you watch the video, you find that things that you didn't see probably during the operation, because your attention was somewhere else. And I remember that I was thinking, wow, this is a difficult case because of the bleeding, but now it doesn't look so bad to me. You will see that there's bleeding often, tendency to bleed, many vessels. Probably now we're getting to see that, and that's the Magneto in action. You see, that's the Magneto in action. The longer pulses of the Magneto are similar to those of a thulium laser, or a thulium fiber laser. So these pulses are quite long, and that we know that enhances hemostasis. My colleagues in in my hospital are quite who do stones are quite impressed by the ability of this setting to produce very fine dust with very, very low retropulsion. So the initial experience, both for me as an enucleator and for my colleagues as stone breakers, is very, very positive. So we are quite happy. We have to see if we can gather some data and start publishing, or getting more objective comparisons, as we were with previous settings, normal coagulation with long pulse, or the bubble blast setting that other people is using for coagulation. But as I said, my feeling was that I had a consistent way to stop the bleeding, a little bit more consistent and more trustworthy. For example, here, this is Magneto. I was also curious to see how it behaved with bigger vessels. And you can see that the long pulse is allowing for excellent coagulation of the bleeders. There we go, a little more for you. But my subjective idea was that this is an improvement. So maybe we are starting to see the Holy Grail, which was the perfect tool for enucleation. When we had the single pulse Holmiums, there was complaints about the quality of hemostasis or first pass hemostasis after Holmium. When we got Thulium lasers for enucleation, we thought, wow, cutting and hemostasis is very good. But we lost the ability of dissecting the pulse thanks to these wonderful Holmium pulses that generate a pressure wave that opens the plane. So there have always been drawbacks to every laser, and advantages, of course. Virtual basket, Moses, very nice double pulse. Some people perceived that the punch of the dissection was a little bit less. Here again, this is all Magneto, I think. I'm going through the bloody area anteriorly and laterally. You see, here's where the prostatic arteries often come in. So I was using the Magneto to try to, and here in the big prostate, I'm spending more time during hemostasis, during the enucleation, because I want to progress safely. And you see, often when you go back to the areas that you dissected before, you can see that there's a red color in the surface and some probably little or not so little bleeders that you have to go through. And this is all Magneto. You see that it is providing a very nice hemostasis. And also, we get very easily to this anterior part now that we have our endoscope on top of the adenoma, so we are able to push it down a little bit, and this brings this anterior aspect, even the bladder neck, very close to where we are. We don't need to tilt the endoscope too much to get to that place, because we're bringing down the adenoma. When you push the adenoma in the bladder later on, you will feel that it is much more difficult to reach up there, because you no longer have this advantage to be able to push the adenoma downwards. And you see, when we enter the other side, we see again that clots are forming, so there is some bleeding in the area, and we have to go, and be quite thorough with coagulation before progressing with the operation. Usually I say that this is time well spent, because now we have the advantage of having a very fast flow of the water between adenoma and capsule. It's a very narrow space between adenoma and capsule, so the irrigation is very efficient. This is what I refer to as the laminar flow of the water that we get when we are working between capsule and adenoma, when the adenoma is still present in the fossa. You see, we get very good visibility. But if you finish the enucleation and disregard all these vessels, often you push the adenoma in the bladder, and then the visibility is much worse because there are several vessels at the same time, and because we lose this laminar flow and we get a more chaotic flow inside the fossa. So the ability to wash and also the water coming out sometimes brings in some blood coming from another place. So at the end, the visibility is not so good. So you can see that I perceived in this case that there was a higher tendency to bleed. I've never been sure if the blood pressure is so important to, for the bleeding. Many surgeons say so, like, it was very bloody because the patient had a very high blood pressure. I'm not sure if it's so important, but well, probably it is a little. But here there was a conjunction of factors, a big prostate and a high blood pressure, big vessels, probably, I don't know, inflammation that could justify, more bleeding. So here I am continuing now. You saw that we entered the bladder. You saw that we dissected laterally. Now I'm trying to progress. That there the plane is a little bit thin. So in these cases we have to keep the fiber closer to the adenoma to try to progress without deepening deeper, or deepening the going deeper. And also at the same time trying to carry a line that we can recognize and we can follow. So here I was getting the fiber closer to the side of the adenoma to try to progress in the dissection. Often when you find that it is difficult to continue with the dissection because there's not so much space, you feel the weight of the adenoma on top of the endoscope, you find that there is difficulty with access. This is a matter of surgical strategy. You have to release more in other parts of the prostate, because when you release the attachments, the mobility of the apical part of the prostate that has been released from the capsule gets better and better. The prostate is mobilized better, and this mobilization will give you better access. So sometimes, especially in the very large glands, with an en bloc approach, you need to be strategic and understand that if you don't release from, mostly circumferentially, if you don't release the attachments, there will be areas that are more difficult to access. And again, here I am using the Magneto, you see, because I see that the surface of the capsule is getting red again, which means that probably there are tiny little veins bleeding, and I want to be as thorough as I can because then of course we have the challenge of morcellation, and in order to reach that moment with good visibility, you have no other possibility. Here you have to work your way, try to progress. I want to push the operation forward, and that's why you don't stop. And that's why doing large glands is difficult for beginners at the beginning, because you need to have the skill to work mostly continuously, to avoid doing a lot of pausing time. You need to have the orientation and the knowledge or the experience or the to be able to work in a little bit more challenging conditions. Here I think for a moment I suspected there was a bleeder. That's bladder neck opening, bladder neck mucosa. The middle lobe is medial to that. And here I want to check also the position of the UO. It was quite lateral on the other side. Here I didn't see it very well. So let's do a little bit more dissection and maybe more hemostasis before we can go back. And it is helpful to know where is one UO, because you imagine that the other UO is more or less situated symmetrically. But as you saw, I didn't enter the bladder in this case, as I said before, trying to protect the sphincter. So this is the moment to enter and see the UO and try to avoid damaging it. So again, this is posterior line dissection. You see that we are slowly advancing, but I'm not insisting, for example, posteriorly, because I want to liberate on the sides as well. But now I'm taking the advantage that I got in terms of mobility and access, and I'm dissecting the posterior area a little bit more. And trying to connect the posterior to the lateral, always trying to connect the lines to make sure that we have a good orientation system. This is like my GPS, you know, these lines help me understand what's happening and help me orient myself. And here we are improving, but of course the capsule sometimes is quite thin in this area, so you have to point your laser closer to the adenoma so that the energy cuts the attachments between adenoma and capsule, but doesn't penetrate too much. So it's 37 minutes now into the operation. We are progressing. You know, in smaller prostates probably we would be finishing now, but you know, longer prostates mean and bigger prostates mean longer lines of dissection, a little bit more time, and often more need to stop to do hemostasis. No, there's a lot of variation. Here again, we are reaching the bladder neck. You see, I want to come from the bladder neck downwards to connect with the posterior aspect, and you can see it's a very, very long prostate, very, very large. I think probably we took out about 200 grams. I haven't received the pathology report yet, but the bucket was full of tissue, which is an indication that it was a very, very large gland. Okay, so slowly progressing, you know, a little bit more bleeding than usual. Trying to recognize the UO again. And there it is. There's like 1.5 or 2 centimeters distance. And again, we go back with Magneto to try to get a more solid hemostasis of the dissected areas. In this case, virtual basket was not enough to dissect and coagulate at the same time, for the reasons that I mentioned. You know, we see variability. Sometimes we do large prostates and they're a joy to make because the plane is so nice, so easy to develop, and there's so little bleeding. And some other times, you know, we see that, well, there's variability, and it is very nice. And I remember, you know, when I started using Moses and virtual basket, that I already felt much better equipped to do very large prostates than with a classic Holmium. So I started feeling that it was an advantage because of the improved hemostasis. So I really now have the same feeling. You see, there's an area there that is a little bit difficult to access, where the endoscope jumps, you know, when you go from side to side, and yeah, we have to continue, continue releasing, continue mobilizing, continue following the lines, connecting the lines, and you have to have a lot of faith that the case will come to a nice ending. You have to trust the tech and the technique. You have to trust that things are going to go well, and we have spoken before a lot about the attitude. No, the attitude of the enucleation surgeon must be very relaxed, very technical. You know, you will deal with the problems that you find on your way as they come, but not with anxiety, not with fear, but with a technical mentality. Now, we can see what's going on, and then we will take the right decision to handle the situation. Here you see my line, or the shape maybe of the prostate is not perfectly uniform. It's not like a billiard ball, you know. The prostate has sometimes funny shapes. That I suspect is an ejaculatory duct. You see that little white cylinder there. And here I'm trying to dissect even, 1 or 2 millimeters of dissection depth with each pass. It's a joy, because the more you mobilize, the more you see, the better access you have. But you see, it seems that we have some kind of step there that is not so easy to reach. My advice is, of course, try to improve. But if you get stuck in these situations, if you get stuck in an area and you cannot continue, you cannot gain too much advancement, then of course you have to go somewhere else and continue the dissection where you can, because mobilizing other spots will help you access this better later on. So don't get stuck, don't get desperate. Just try to gain millimeters, and if you cannot progress here, go somewhere else. That is the middle lobe pocket area. So we are now under the middle lobe, and it is this side that seems to be a little bit more sticky and a little bit more difficult to access with this jump of the cystoscope. You see, I cannot see very well what's going on down there, and I feel the weight of the adenoma on my endoscope when I try to reach there. So let's go somewhere else, continue, because I think also in the large glands, some people say you cannot do and block in large glands because the transverse diameter of the prostate is much bigger than the transverse diameter of the bladder neck. But here we use a nice trick, and this is to try to connect the posterior plane with the bladder neck. See that we have detached nearly all the attachment of this lobe to the bladder neck, so that we have a nice view here, for example, of the bladder. You see, we try to cut all these attachments and cut the bladder neck going downwards. Let's see where we get here. You see, coming towards the midline, and then that is going to help us luxate or mobilize or tilt this side of the adenoma into the bladder. This is trial number 1, which failed, and I'm pushing really gently until I can luxate. You see, I can push, and here I'm back with Magneto to check. But you see that the left lobe of the patient has already been tilted into the bladder. So you see, by applying a rotational movement, we can initially tilt one lobe, and this is going to generate an improvement in the access to the lower aspect of the adenoma, because we will have more space now But again, this is Magneto trying to get a good hemostasis in a challenging case where, you know, there's a huge tendency to bleed, and you know, the situation is a little bit tricky and difficult. Also, of course, the surface we have to cover is big. This is like an orange, this prostate. Okay, there's not so much clot formation there, but you see now we can get to see the jump that we couldn't see before, because the mobilization of the adenoma, the gentle mobilization of the adenoma, has allowed me to gain more space and to see this area and to touch it very easily. Of course, when I do the pushing of the lobe into the bladder, I don't push very hard, because if you have attachments here, often you can pull from these attachments and you could break the capsule by trying to force the entry of one of the lobes into the bladder. So you have to liberate as far as you can go, then mobilize one lobe very gently. If it doesn't go, don't push, try to dissect a little bit more. And then you see here, now we are nearing the completion of the enucleation, and this is now 46 minutes. But again, you know, I know that it is better to do the hemostasis when there's still a significant amount of prostate inside the fossa, because we benefit from this better flow, you see, and sometimes we find the bleeders that are causing the trouble. And here I'm doing a systematic coagulation with the longer pulse, and you can see the beautiful hemostatic effect of this setting when we had already passed with the virtual basket. So very nice feeling of having a reliable tool for coagulation, and I felt very well equipped to do a challenging case, because before, you know, often I would resort, if I needed to get in with a resectoscope and do a rollable coagulation prior to morcellation when I couldn't get good hemostasis. But you will see that despite, you know, being a big surface and, you know, needing a lot of time to do hemostasis to cover all this surface, the reliability of the hemostasis is quite impressive. And but you need to spend the time that you need to spend. You know, each case has its own. But I would say in a degree of difficulty, this was a difficult case. The tendency to bleed of the patient was not so, you know, I wasn't so happy with the way that things were going. But then, of course, having this ability to coagulate really helped and made me feel very safe. Of course, you have to keep your emotions down. You know, you have to be a Vulcan, Star Trek Vulcan. You know, you have to be very logical and very dispassionate, or that's it. Oh, there it is. Okay, so there's time, and now this is now 49 minutes of enucleation time for this huge prostate. And now again I will spend more time doing coagulation, but until I can see well enough to start the morcellation. So, but I was so happy with my new, you know, toy, and testing the ability of this new setting to improve our experience. And I thought it was relevant enough to bring you this this video, no, to publish it. I got a message from one urologist from South America who had been watching cases with me, and he said, well, we're thinking to buy a 60-watt laser and a cheap morcellator, and I told him, try to get the best equipment you can get, because when you face difficult cases like this, working with, substandard, or I don't know how to say without being offensive, working with a laser that doesn't really give you the best features, to face these challenging cases is a pain, and maybe this operation that took 1 hour and 15 minutes could take much longer. So at the end, my feeling is when you start doing HoLEP, especially if you can get good outcomes, low incontinence rates, you're going to have very, very happy patients. Not only after 6 months, but post-operatively, the great majority of patients are very happy. They can pee very well. They hold their urine, and they leave that with a big relief, because they heard about the chance of having incontinence. And then they send you patients. They send you a lot of patients, and you're going to operate progressively more and more. Your numbers are going to grow. I don't know if I can say exponentially, but if you are going to start doing HoLEP and you think that, I don't know, I do 30 cases a year of TURP, or 40 or 50, the likelihood is that you're going to very fast double that number doing HoLEP, and it's going to grow and grow and grow every year. So if you're going to, finance the laser, and that's the sphincter, it looks very good. Sphincteric preservation. The patient was continent post-operatively, so I was very happy too, because in these big prostates, probably there's a little bit higher chance of stress incontinence post-operatively, because of the amount of and the degree of the movements you have to do. So here I was trying to go through all the surface. Remember, the patient had this high blood pressure and tendency to bleed, so I was trying to be patient. Here I think the patient was like coughing or something. Not coughing, but making abdominal strain, and I think for some time he was having nausea or something. And I was impressed when the anesthetist gave him alcohol to smell. I didn't know that, but apparently when the patient gets a little bit nausea, if you give him alcohol to smell, things seem to be a little bit better. Maybe because you remember the good times drinking with your friends or something. No, but jokes apart, you see, the patient was not giving us a lot of... It was difficult. It was difficult. It was a challenging case, and then he started having this nausea and movements. So it's difficult to work. Luckily, he stopped, and we were able to morcellate very, very nicely. Also, the morcellation was excellent. So the behavior of the morcellator was really, really good, and we could take a lot of tissue in a very short time. So probably getting more than 10 grams per minute, which is not always the case. Sometimes the prostatic tissue is soft. Sometimes the prostatic tissue is a little bit harder. Sometimes the morcellator is operating at full efficiency. For some reason, the suction is very good. And one thing that I heard from the Piranha system is that it doesn't work well in very high places. Like I was invited to go to Bogota in the near future, and I couldn't. They told me you cannot use the Piranha there because the atmospheric pressure is very low, because this Bogota is very high over the sea level. So, and here I decided it was worth trying to start the morcellation. And we did the change of instrument, hoping that I had done enough hemostasis. Sometimes these decisions influence how the operation goes, in the sense that if you can go in and do morcellation all right, it's fast, but you might regret, let's say, not doing additional hemostasis. But I was quite impressed with this Magneto, and I thought, there's a big fossa, there's some clots already, and I don't think I can make the hemostasis better than this. Or well, I thought it was enough. And then I entered with the morcellator. I got a reference of the bladder neck. I positioned the morcellator blade about 2 centimeters over the bladder neck, which is what I call the safety position, and then started the morcellation. Initially, I saw some red. I was not completely sure that we could progress safely with this morcellation of a very large piece. But I was happy to see that the contact of the tissue with the morcellator blade was quite good. This usually means that there's a lot of tissue going out and not so much water. So you can keep morcellating knowing that the bladder is still distended. No? As many of you know, I use only one inflow with my equipment. But of course, this is based on a lot of experience, and I do that because I want to try to make the procedure very simple, and it's a little bit cumbersome to have a second inflow with another 2 bags. But I have to say that sometimes I do. Sometimes I decide to have an extra irrigation line. In this case, it was not necessary. Of course, if you're tackling a case like this for the first time, it might make sense to go in with a rolly ball, doing the best possible coagulation you can get prior to morcellation, because you need, let's say, nearly perfect visibility to morcellate. In this case, the visibility is just good enough. It's not perfect. You see, there is a problem with the cameras, because as you can see, the light incites directly into the adenoma and reflects a very bright light. So the camera system adapts to this brightness, and in contrast, the lower part of the image is very dark, so we cannot see. We can see the black triangles lateral to the blade in both sides. To me, that is a sign of tranquility. I mean, I am of safety. I know that I'm not close to the bladder because I see black. But it would be much better if we could see the bladder wall, if we could have detail, which probably we would have if there wasn't this very bright light, in the upper part. So it would be interesting to discuss with the companies if they could do, split the screen in 2 parts, the anterior part and the posterior part, and probably do individual light adjustments, so we could see the bright adenoma on top, but we could also see the bladder through these lateral triangles. Just an idea. And there we are, progressing with morcellation. You see why I insist so much in this technical mentality and passionless, Vulcan attitude to enucleation, because I think that you need to reach the morcellation phase when you're still fresh. If you are stressed during the operation, when you reach the morcellation phase, you're going to be very tired. And here is where you want to be 100% looking at the screen and be ready to stop morcellation if something happens, and prevent a bladder mucosal perforation and etc. You have to keep all your senses to the task, focused on the task, and this needs sometimes in cases like this, it was like 15 to 20 minutes of morcellation. So you need to remain fully focused on what you're doing. And if you're very tired, it's going to be difficult to perform properly. So the enucleation phase should be joyful, relaxed, technical. If you have a challenge, it doesn't mean that you cannot surpass it. The challenges are there to be tackled technically. And so when you get to morcellation, you're quite relaxed and happy, not tired. And then you can focus all your attention in the morcellation. But to summarize my feeling with this new Magneto development, I think it is I love engineers. I think they are so clever, and the way they think and the way they put this new developments in our hands, it's amazing. And I think it's wonderful that their job is going to benefit so many people in the world, and this to me is a similar, let's say, breakthrough or improvement as the improvement I felt we had when we started using Moses and virtual basket, pulse modulation. And from what I hear, because I think the hearts of the stone surgeons was a little bit split. Some stone surgeons liked TFL, but they still thought that Holmium was a better choice for harder stones and probably bigger stones, and so they had a split heart. And now they can have in the same machine, they can have settings that allow them to go from very powerful fragmenting of the stone to dusting. So I think it's a very, very relevant step forward. Of course, these things, we need to see publications. Probably the how do you say that, the general results of enucleation are already very good with any of the commercially available lasers today, and proving very significant differences is going to be challenging, because we already have very, very happy, very good results, very happy patients. But when you notice the difference of having a better tool is when you work intensively, like we do 5 or 6 HoLEPs in our sessions, and the fact that you can move through the case relatively fast, even when it's difficult, and you have these reliable hemostatic properties. I think it's a great thing, because you can work efficiently. And in this particular session, we did a radical prostatectomy with an extended lymphadenectomy that took about 2 hours, and then we did this case and 3 more cases of HoLEP. So typically the other cases were relatively small glands, 50-60 grams, and they took probably 25 minutes each or something. So we have a very, very energetic team of nurses that allow us to do a very fast change, cleaning, and starting again, so we can run these lists, and there is where you notice how technology helps you, a faster morcellation, like we are getting with Piranha compared to other morcellators. So all these details count, and that's why when they ask me for advice, I say, steal the money, get the money however you can, spend a little bit, risk a little bit more, and of course get the good tools, because you might be starting with a low power laser, 60 watts or something, but you're going to suffer much more, especially in the difficult cases. And I think this is an operation that needs maximal technology. You want the best tools that you can find to perform these operations, because sometimes they put you to test, no? And I don't know if there's anything else I can tell you about Magneto. It's interesting, I think Cesare Scafone is doing low power, 30 watt enucleation with Magneto setting, which to me would be similar to doing probably low power enucleation with Thulium. Everything is feasible and possible, huh? I have chosen to stick to virtual basket 250 to joules 50 hertz and Magneto just for coagulation, and I think it's going to be a killer combination. And so I hope you enjoy the video again, and I thank the feedback. Many people write me and tell me that these videos have been helpful, and this of course keeps me motivated to continue adding information. I think that I'm very repetitive, because I use the same arguments and mostly we go over and over again over the same thing. But it's interesting that I get visitors that come with me to sessions where we do 25 or 30 cases in 4 days, and they tell me that this is a much better experience than just watching the videos, because they see the operative room, they see my hands as I manipulate the endoscope, and they get a lot of tips, that the videos cannot easily show or convey. So, but still, I think it's probably nice for people who are interested in Holmium and improving to see the real life cases that we face, and you will agree with me that the morcellation efficiency was really good. The prostate never leaves the mouth of the morcellator, so we were able to take a lot of tissue in one go. I had to do a change, I think, of the canister of the bucket of water for a moment, so probably we will be stopping before we finish, but we took out a lot of tissue in the first go, and then we had to finish the morcellation. So what is clear to me now is that there's a huge interest in HoLEP. Many hospitals want to adopt it, want to do it. There's a huge interest in learning, and many young people are seeing an opportunity in performing HoLEP. And many people who work privately, they see a big opportunity to adopt a technology that is going to drive a lot of patients and a lot of success. But of course, it is important to have attention to detail and learn how to avoid the important problems, the important complications, because in our center, this is a very, very straightforward operation that we do quite fast. Patients go home the next day without a catheter. Some centers are doing ambulatory surgery. When you go to experience centers, you can see that this is you see here, the morcellation was losing a little bit of its efficiency. Sometimes the pipes are blocked with tissue, and you get less suction and less efficiency. So at a certain moment, I think we stopped before completing morcellation. So if I see that this wonderful engagement of the adenoma is getting worse and worse, it might mean that the basket for the tissue is full, and the transmission of the vacuum to the tip of the morcellator is less efficient. So as I said, I think if you do HoLEP, for example, and you get a lot of incontinence postoperatively, you have to reevaluate what you're doing. You have to try to do it better. You have to try to revisit how do you deal with the apex, because I tell you, we have very, very low rates, and many people are trying to do early apical release. Many people are trying to do mucosal sphincters mucosa protection. This is the moment of the change. You see that there's no activity because they're changing the both the tissue basket and the bucket, and now we will get improved suction. But you can see the hemostasis is very stable. We don't see more blood than at the beginning. It's not perfect because it's a big fossa, and probably there is some oozing in the fossa, but we can see, and we can perform a very fast morcellation of a big piece. And so I'm losing my what I wanted to say before. I'm getting old, I think. But it was related to more and more people trying to learn. Yes, if you have bad results, because I see we did a collaborative effort to report data retrospective registry, and when you see this paper, you see that the advantages of early apical release are there, but they're not so evident. But I think it is because of the variability. Many people try to do early apical release, but maybe they don't liberate enough, they don't mobilize enough to do a very respectful liberation of the apex. I recently saw two papers from the group of Humphreys in the US, where one, they have better results of continence and with an early apical release strategy. And also they have described a grading system. They look at the sphincter at the end of the procedure, and they give it grade 0 when the mucosa is perfectly covering the sphincter all around, grade 3 when it's quite damaged, and they have seen a correlation with the aspect of the sphincter at the end. If you finish the operation and you see a very beautifully epithelialized sphincter, the chances that this patient is going to be continent are very, very high, which is something we have observed. But they did a paper on, I think, nearly 100 patients. So I think more and more we are understanding that this is a useful approach, and that it can minimize the rate of postoperative stress incontinence. And so it's nice that you can evaluate your own results, and if you get 10%, 15% incontinence rate, there's definitely something that has to be improved, and then it might be worth that you look at these videos and try to make your own conclusions and try to change some things, especially handling the cystoscope very carefully. There's a small clot you see on the fossa forming, and this is, but I'm quite happy because it was a very, very stressful case, very high blood pressure, big prostate, and we could finalize it in a very short time. Thank you for your attention again, and all the best to everybody. Let's hope this year will bring us a lot of happiness.